everyone. Welcome to Grand Rounds. My name is Dr. Jared Mabey, one of the chief residents here in Boise, and our speaker today is Dr. Ramasamy. He's an attending in child and adolescent psychiatry and the interim medical director in the psychiatry and behavioral medicine unit at Seattle Children's Hospital. Also an assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington School of Medicine. All right, Dr. Ramasamy, thanks for coming. Take it away.
Hi, we actually also have two other presenters with me who I can introduce. We have Avery Wade, who also works at Seattle Children's. And we have Gabrielle Curry, who is a forensics fellow at OHSU and a recent graduate of our child and adolescent fellowship program. So Avery will actually be starting us off. Are we able to share screen?
We are. Wait, maybe not. Oh wait, yes, here we go. Okay. Sorry, I'm like the least technologically savvy person. All right. Can everybody see this? Good to go. All right. I'm gonna mute and Avery just tell me when to switch slides.
Okay. Alrighty. Well, here we are to present our study on implicit bias training, or how implicit bias training decreases racial disparities in restraint use on a pediatric inpatient psychiatry unit. My name is Avery. I'm currently working at the hospital. We also have Dr. Curry and Dr. Ramasamy, who will also be presenting. Next slide. Thank you. So our objectives today is to understand systemic racism, anti-racism, biases, both implicit and explicit, highlighting adultification, and then seclusion and restraint. We'll also recognize their effects on social determinants of health, diagnoses, treatment, access, outcomes, and seclusion and restraints. And lastly, we'll talk about interventions, the implicit bias test, and the PBMU study. And so for our definition of systemic racism, a form of racism that is pervasively and deeply embedded in systems, laws, written or unwritten policies, and entrenched practices and beliefs that produce, condone, and perpetuate widespread unfair treatment and oppression of Black, Indigenous, and people of color. Within our healthcare system, BIPOC patients are experiencing adverse health consequences due to the systemic racism experienced through hospital practices. For anti-racism, powerful collection of anti-racist policies that lead to racial equity and substantiated by anti-racist ideas. Any idea that suggests that racial groups are equals to all their apparent differences. Anti-racist policy is any measure that produces or sustains racial equity between racial groups. Racial equity when two or more racial groups are standing on a relatively equal footing. Policy, written and unwritten laws, rules, procedures, processes, regulations, and guidelines that govern people. Every policy in every institution, community, and nation produces or sustains either racial inequity or equity between racial groups, and no policy is non-racist or race neutral. Framework for reviewing individual and systemic levels, behaviors, and policy decisions not permanent or absolute, but instead based on an individual's ideas and actions in a given moment and represent an ideal to strive towards rather than a finite goal that can be achieved. For biases, we have explicit bias, which is the preference, beliefs, and attitudes of which people are generally consciously aware and can, when willing, identify and communicate with others. So, and then on the other end, we have implicit bias, which is unconscious involuntary attitude that influence affect, behaviors, and cognition and are strongly associated with inequitable outcomes than explicit discrimination. And both are and can be harmful and impact feelings, behaviors, judgments, and outcomes. Next slide. Adultification is what we wanted to specify on. So adultification's bias is a form of racial prejudice where children of minority groups are treated as being more mature than they actually are by a reasonable social standard of development. And even though this can be unconscious, it is still unacceptable and can be very harmful. To define seclusion, the involuntary confinement of patients alone in a room or area from which the patient is physically prevented from leaving. Seclusion may be used only for the management of violent or self-destructive behavior. Restraints, any manual method, physical or mechanical device, material, or equipment that immobilizes or reduces the ability of a patient to move his or her arms, legs, body, or head freely. A drug is considered a restraint when it is used as a restriction to manage the patient's behavior or restrict the patient's freedom of movement and is not a standard treatment or dosage for the patient's condition. Chemical restraint. Physical restraints are commonly used in healthcare settings for patients of all ages, particularly in patient psychiatric units, used in situations where they are necessary to preserve the safety of an individual at imminent risk of harm to themselves and or others. And so for the effects of systemic racism and implicit bias, the social determinants of health, access to care, diagnoses, types of treatment, and then outcomes, which are the seclusion and restraints.
Thanks, Avery. Yeah, so I'll just be talking about kind of the clinical relevance for all of these things. Many of these definitions, I'm sure you guys have encountered at some point, and since we are all psychiatrists of some sort, we've definitely all been comfortable seeing, restraints, seclusions in various inpatient settings. Next slide. So a lot of these things have been studied fairly extensively and have found pretty consistently that implicit bias does impact patient care. This has been found, I think, in pretty much every specialty and subspecialty. This literature review that I'm referencing looked at every study that was done on implicit bias in healthcare providers, and pretty much many of them showed very clear evidence of bias across training levels, across disciplines, across specialties. Whether using clinical vignettes or simulated patients, this was also demonstrated. And it did have a fairly direct impact in treatment recommendations, just the therapeutic relationship between patient and provider, pain management, empathy, several other factors. So what this kind of tells us is people's implicit biases are one of the factors, not the only factor, but one of the factors that drive these healthcare disparities that we see and, over the last few years have been increasingly written about. But what has not necessarily been researched or written about so much extensively is, what do we do to reduce the bias? How do we even measure that? How do we even figure out how to do that? So, next slide. I think if you click on the Grand Rounds PowerPoint tab, yeah. Many of you have probably seen this onion model. If you've gone to any UW lecture at some point. And I want you to sort of focus on the social determinants of health part of it. But this is kind of like a bird's eye view model of how we think about disease. But social determinants of health, they're the conditions that people are born into and live in that affect their health. And some of these things we think about more readily than others, but they all have shown to be impactful in people's health, both positively and negatively. So anything from demographic factors like race, ethnicity, assigned sex at birth, sexuality, gender identity, also socioeconomic things like income, access to housing and utilities, access to jobs, and safety. So community trauma, like neighborhood crime rates, all of these things have shown to impact not just mental health and emotional health, but also physical health. But if we focus a little bit more on mental health, another important point is the way that these social determinants of health impact people might be different based on their demographic factors. So this example of this study that was done in 2017 showed that while higher income can be protective against a major depressive episode for white women, it's actually a risk factor for depression for Black men. Next slide. And there are a number of different ways that racism, implicit bias impact child and adolescent psychiatry, whether it's access to care, diagnosis, treatment, outcomes. So we'll talk a little bit about that. This is probably the largest study that I have seen to determine like the prevalence of psychiatric disorders in children. So the study was done on children aged 2 to 17. So I've shown the overall prevalence of disorders in all children. But when we look at how this differs for white children versus ethnic minorities, we find that white children are more likely reported to have a disorder than minorities. There are a number of reasons for that. And white children also receive treatment at a much higher rate than every other group. The other demographic factors that, sorry. The other demographic factors also have an impact, such as like insurance and overall socioeconomic status. When we think about diagnosis, one study that was done in 2016 in Florida among a population of juvenile offenders, both males and females. So these are individuals that are living in juvenile detention, and you're controlling for many things like their exposure to trauma, their history of criminal offending behavior, but also things like access to care. I mean, they all have the same access to care because they're all in the same facility. So even in that controlled sample, we found that Black males and females far more likely to be diagnosed with conduct disorder compared to their white peers, less likely to be diagnosed with ADHD, and yet less likely to receive treatment, even when controlling for access. And those of you who have rotated with me on the PBMU probably heard me talk about conduct disorder. Conduct disorder is one of the things in child psychiatry that is associated with the school to prison pipeline. And it is one of probably the biggest diagnostic sources of bias as far as child psychiatry goes in the DSM. And it, like I said, affects treatment. We find that white youth significantly more likely to be prescribed psychotropic medications, whether or not they have a disorder. And then, we often lump together minority groups and don't necessarily appreciate the pretty significant differences between minority groups and even within minority groups. This study was actually done at Seattle Children's to compare, immigrants versus non-immigrants to see how that impacts mental health. Immigrants across the board had higher rates of depression than non-immigrants. And another interesting point was among Black individuals, non-immigrants actually had higher rates of behavioral issues than immigrants. So that can kind of teach you a little bit about how intersectionality or viewing several sources of bias together can change outcomes. So many of you are probably familiar with the ACEs study and questionnaire. The next slide. And this study that was done on ACEs, I would say the biggest point is, while we sometimes think of socioeconomic status as protective, the impact of certain traumas seems to overcome those protective factors and still impact people's health. And even in something that we think of as a bit more objective, we'll say, like diagnosing autism, like we have measures for this, we have validated ways of doing this, but sometimes we don't always think about which populations these studies are actually validated in, because sometimes these things can look different in different people. So this one just looked at prevalence and how socioeconomic status impacts that. Prevalence of autism spectrum disorder increased with socioeconomic status in all racial ethnic groups. But those differences still remained after controlling for socioeconomic status. So it's not the only factor. And even in these so-called objective measures that we use, we do find item level bias in some things. So this study looked at the items on the ADOS, which is one of the most common ways that we diagnose autism, and things like eye contact, stereotypies, idiosyncratic use of certain words and phrases. There is some difference in race ethnicity. And so cultural factors can impact who gets these diagnoses. So going back to kind of our main discussion point of seclusion and restraint, we find that, despite these restraints being common on psychiatric units, and we've been using them for years and years and years, we've not actually demonstrated through research that they have any benefit for safety or reducing disruptive behaviors. And there's actually a lot of evidence that they worsen those things. There's lots and lots of risks, both to the patient, to the milieu, and to the staff involved in the restraint, including and not limited to significant trauma and even death. A study that was done that looked at restraint-related deaths from 93 to 2018 found nearly 80 pediatric deaths across the children's welfare, corrections, mental health, and disability services. And even more recently, we see examples of this in the news. Cedric Lofton, who's a 17-year-old Black male, died back in September 2020 after being restrained while in the prone position, while incarcerated in a detention facility. When I was a fellow in Chicago back in like 2016, 2013, whenever I was a fellow, there was a reported death in one of the residential facilities in Illinois. And it was a facility that we frequently would have kids go to for treatment after hospitalization. And this is also impacted heavily by bias. So BIPOC patients are physically restrained at disproportionately higher rates than their white peers. And despite the fact that we know this, and it's demonstrated pretty much nationwide, there's not a lot of research on identifying like what drives that or how to intervene. We think that the concept of adultification, partially explains this, but there are probably several other factors. And, there are other risk factor groups that are also prone to increased seclusion and restraint incidents. So people with intellectual developmental disabilities, people with difficulty communicating, anyone exposed to trauma. And this has a huge impact on staff as well. Research has demonstrated, increased risk of physical and psychological trauma, which is, I think, also easy to see and understand in our roles, as well as burnout and ultimately staff turnover. I included this quote most of the time we're not the ones that are doing the actual restraint, but we maybe don't have a great understanding of what that is like for the people doing it. So I will read this. For the remainder of my shift, and this was following a restraint, for the remainder of my shift, I sat in the nursing station because I couldn't focus. After my shift, I went and talked to my manager. I brought up the restraint that had happened, tried to explain how it made me feel. Broke down crying while trying to explain why it shouldn't have happened. In the middle of me processing, it felt like they weren't hearing what I was saying. The moment I was like, okay, this is obviously not something I want to be a part of. And this moral distress, especially on a children's unit, especially for staff who are BIPOC as well, is definitely one of the things that directly leads to staff turnover and psychological trauma. So when we think about what to do about this, how do we reduce the incidence of seclusion and restraint? There are a few interventions and policies that are largely based on trauma-informed care that have demonstrated some effectiveness in decreasing the overall incidence of restraints, but currently no evidence-based interventions on how to reduce or mitigate the racial ethnic disparities in things like restraints. And there's overall been a lack of dedicated research or funding in this area. And with that, I'll turn it over to Dr. Curry.
All right. So I added this slide just recently. I don't know if any of you guys heard this story. Just show of hands, have any of you guys heard this story from Twitter? Okay, so this happened fairly recently. It was maybe a few weeks ago, and really just demonstrates, I think, how clearly we need just more across the board. We need more people of color in every space because it really shapes and informs so much of patient care and like the outcomes like Ravi and Avery have been talking about. So there was a girl that came in with stroke-like symptoms and needed an MRI, and she was wearing a lace front wig. Show of hands with the people with their video on. How many of you guys know what a lace front wig is? Yeah, okay. So she came in with a lace front wig. It's a wig that has been glued down and there are metal pins on it. And so they couldn't give her she couldn't go to the MRI. So, you know, the neurologists, the nurses, all of the staff members are freaking out, trying to figure out how to get this wig off. And thank God there was a Black doctor in the room, and she was like, just give me some alcohol. You just rub some alcohol on it and it comes right off. And if she had not been there, this woman would not have been able to get her MRI, because something that is commonly known in the Black community is not known outside of that community. And so that's just, it just demonstrated to me so perfectly how important it is that we have more diversity and inclusion across the board, because it really does save lives and it impacts everybody. Okay, so coming kind of back to our study, there are a myriad of ways to mitigate unconscious biases, which we all have. And these are things that we need at every level. So yes, it needs to come from the top down, but I think sometimes it can get discouraging or feel overwhelming, because you're like, I can't do this, you know, top down thing because I'm not at the top yet, which is, you know, where I am and where I have often ended up feeling super frustrated, because I'm like, I'm still, you know, pretty low on the totem pole. I'm still a fellow, or I'm just a medical student, or I'm just a resident. And while we do absolutely need all of those things, I am encouraged by this slide because it leaves me feeling like, okay, there are still things that I can do at this level, at the individual level, whether it's just self-reflection on my own personal biases, or questioning and actively countering stereotypes that I encounter. But our intervention and the project that we're talking to you guys about today is one at an organizational level, and that was meaningful diversity training. But again, there are a myriad of different things that can be done, that need to be done. And what we're talking about is just one of those ways. All right, so getting into the nitty-gritty of the project. So started out with a SAMHSA grant that I actually received when I was in residency in Washington, D.C. at Howard. And the pandemic kind of screwed up my project that I had intended to do at Howard, and I had a bunch of money left over when I came to UW. And so our inpatient unit, the PBMU, had already been doing this study where they were looking at the restraints and looking at the disparity in restraints. And one thing that I feel like I see a lot in residencies and fellowships is they make us do these quality improvement projects, right? Like you've all had to do one where you're like, I'm just gonna like jump on, whatever thing is kind of already happening, just to check the box, it feels like a lot of times. And I get so frustrated by that because I'm like, there's so many great projects that just kind of stop after that. They're like, here's this huge issue, and I've looked at it and presented it in this pretty slide, and then I graduate and move on and nothing happens with it. And so the idea that I had was to take this project that a previous fellow had done where they were now able to prove the disparity that everybody kind of already knew was happening, just from our experiences, but we had the data to prove it. And so I said, I want to continue that and say, what can we do to change this? Because this is a huge problem. Like the number that Ravi shared, there were almost 80 pediatric deaths from restraints. Like this is something that is not just emotionally and psychologically taxing, but it's like having a physical impact. So I came up with this plan with the rest of the team that did this with me, and we started out with having everybody take the Harvard Implicit Association test. Are you guys familiar with that? Yeah, okay, I'm seeing some nods, good. So everybody did the IAT and they self-reported their results. Then we did our intervention, which was called Conscious Anti-Racism Training, or CART. After they did the training, we did another IAT and they imported their results. And then we looked at the impact on outcomes and restraints in the period after that. So our training, our intervention was a 2-month period where all of the staff members employed on our PBMU were required to complete this 8-hour training. They were paid for it and also given protected time to be able to do it. It was self-paced, and they also received continuing medical education credits for it. There were 7 different components of the training. There's different modules that each of the staff members had to complete. And then when we were putting our data together, like I said, a prior fellow had already started this project, so we had the database for quality improvement that was already in place. So we examined the data for the 6 months prior to our training, and then the 6 months after our training. And then we further collapsed it into quarters. So there were the quarters before the training and the quarters after the training, 2 quarters each. And all of the staff members were required to complete the training within 30 days of the start of quarter 3. Okay. So a little bit more about CART. This book is written by the 2 women who created this training. So there is Jill Weiner and Maisha Claiborne, and they came together and created this training that has 7 different modules. So the modules were, the first one is mindfulness, and then recognizing and better understanding uncomfortable emotions about racism. I know that every single person in this room has had a situation where there is some conversation or something happens that brings up just uncomfortable emotions, or emotions where you're like, I can't even name it, but I just know this feels kind of, ugh, and I don't know how to talk about it or what to say. So I have a module on that. Cultivating compassion is the next one. Improving communication, processing stress and bias, and setting healthy boundaries. So each of the staff members went through and completed these different modules. And I put a bold on paid training. because not only are you like obviously increasing the likelihood that people are going to do it, but by paying staff, you're indicating that this work is valuable and that it's worth investing not only your time, but also your money in. And so from an organizational level, I think that that is a really important thing, that we're not just saying like, hey, I think you should do some anti-racism training or some anti-bias training. Like, I think that this is a good idea. Like, we'll throw it out once a year and nobody's actually going to do it. By paying staff, requiring it, giving CME credits, things like that, you're indicating with your money that this is something that is necessary and worth investing in. Okay, so our hypotheses. First one was that anti-bias training will lead to a decrease in implicit bias scores on the IAT. So like I said, we had people do the IAT before our intervention and then again after our intervention. And it did. So staff members self-reported pre and post implicit bias training results indicated that there was a reduction in bias from pre to post training. That was the first part. That was pretty easy. The second part was that decreased implicit bias will be associated with decreased disparity in restraint use on the PBMU. And it was. So I still remember when I got the email from Alicia, who's the person that does all the data for us, because I am not mathematically inclined at all. And so she explained all of this in a way that made sense to me. But just saying that it was a statistically significant difference in the racial and ethnic groups and who was restrained. So I have a couple of graphs, which I'm going to do my very best to not screw up. So looking at this graph, I realize now it's kind of blurry, but it's broken down by different racial or ethnic groups. So there's American Indian and Alaska Native, Asian, Black or African American, Hispanic, so on and so forth. And then the different colors represent the percent of the population is the darker shade, and then the lighter shade is the percent of restraints that race made up. And then blue is Q1, orange is Q2, gray is Q3, and yellow is Q4. Sorry, I know I'm throwing a lot of data at you, but if you look specifically at Black or African American, and then non-Hispanic white, so you can see in Q1, Black kids made up about 6% of the population on the PBMU and 11.6% of the kids that ended up needing a restraint or getting a restraint. Same in Q2, they made up about 3.3% of the population, but almost 6% of the restraints. So you can see in both Q1 and Q2, there is almost a doubling of the percent of kids admitted to the kids restrained. Whereas if you look at the white population, it's pretty even. You know, across the board, they're 50-some% of the population and 51% of the restraints. So super even here and very disproportional for the Black kids. So then moving on to after our intervention, starting with the gray in Q3, you can see that for the Black kids, and I can't read this number, but just looking at the picture, you can see that it's not nearly as close to that doubling in the percentage of kids admitted to kids restrained. So that was our Q3. Right after we did the intervention, we saw this huge decrease. And then unfortunately, when you move into Q4, it went back to the double percentage. And I know that I'm running short on time, which is kind of why I'm rushing through and just focusing on those two because they show it most clearly. Okay, so this one, same Q1, Q2, Q3, and Q4. And you're looking at restraints per 100 patient days by race. So the line across the screen horizontally shows you what the average is, and then you can compare by race how they did compared to the average. So in Q1, you can see the average is way down here, and for Black kids, the number of restraints is more than double, whereas non-Hispanic white, it's under right about at the same number. And then that goes down in Q3, which is again the quarter immediately after our training, where the average is here. For Black kids, we're down here. Hispanic kids also under the average. White kids were just above. But then again, Q4, you see this huge spike. All right, so what does it mean? We're throwing all this data at you, saying that it worked, but only for a little while, only for those 3 months, and then stopped working. So, what does that mean? Do we just throw it all away, say, man, I really thought that this was it, and then guess not, because it's not sustained? I would argue no. What we took away from this is that this training and this work is important and that it does have an impact, but it needs to be ongoing. So you think about all the other things that we do continual training for, even in like general psychiatry. So I've been out of general psychiatry residency since 2020, and there are already things that I used every single day that I was like, I know this down pat, because I use it every day, but I haven't prescribed a medication for an adult patient since 2020. And there are things like, even if it's just simple like dosing of whatever medication that I haven't prescribed in forever, that I'm like, I need to like double check that. It's the same thing for this type of training. It's not something that you can take for granted, that you do once and you're like, oh, I did that, got the box checked, we're all good to go. It's something that you have to do ongoing to make sure that those results are sustained, that you are still aware of your biases, because we're being just flooded with things all day long from the media, from everything that we see, everything that we exist in this culture. So we have to be really proactive about fighting against that, and those racist, problematic things that we see every single day. And then we also want to just study more about decreased bias in other disparities. So LGBTQIA individuals, insurance payer status, socioeconomic status, PRN and IM use, length of stay, diagnoses. So in conclusion, anti-bias training can decrease bias. Decreased bias can be associated with decreased harm. Reduction in harm is not sustained, and therefore anti-bias training needs to be ongoing. And that is all we got. Sorry, I went a little bit over. I know we wanted to have a little bit more time for questions, but happy to take any questions now. And if there is anything that you guys want to ask us, or questions or comments, feel free to email any of us as well. We'll stop sharing now.
Does anyone have any questions, comments, thoughts?
Were you looking at physical restraints in this, or like medication administration, or is this focused just on physical restraints?
This was just physical restraints.
Yeah.
Was there anything in particular with the fourth quarter kind of recurrence that any ideas you had about that? I mean, I saw that on the slide you mentioned staff turnover. I was curious about if you had any thoughts about what really was driving that. If it was staff turnover, or any staff members were maybe interviewed to give their thoughts on what they thought was going on.
That is a great question. There are a couple different things that I know off the bat. So our unit doesn't have a lot of kids of color. I think it's usually like over 50% are white. And so sometimes you might have one kid that is admitted that has significant behavioral problems that just gets restrained over and over and over and over again. And so I know that was one thing that we had thought about for quarter four. I think there was a particular child that was admitted that may have driven some of that.
Yeah, our numbers can be easily affected by one or two kids here and there sometimes.
I also do want to throw into that. You mentioned about staff turnover. We haven't examined that, but I do also believe for quarter four that was a potential factor too, because those new staff that were coming in hadn't received the training, and there was a mass hiring during that session due to the loss of a lot of members prior.
Yeah, the training took place in October of 2021. So anyone hired after that wouldn't have gotten it. And when we think about how many of the staff that got the training even remain, I mean, our most recent turnover is 82%, which is considerably higher than we're used to. But our average is still like 40%. So turnover would definitely impact that pretty significantly.
I'm wondering if you gave any thought to the impact of the milieu on inpatient kids of color, in terms of, being in a predominantly white space. It seems like a lot of this could be set off too by the attitudes and postures and behaviors of some of the other white patients on the unit. And if there was any look at that, and I don't know what you do about it, but.
We didn't look at that specifically, partly just because it's a kind of a difficult thing to measure. But I can also say that that situation does frequently arise. So it's something that we're seeing happen. We've recently had kind of an issue with like white patients saying racial slurs both to staff and patients of color, which we know has a tremendous impact on both, and has definitely led to increased safety events kind of across the board.
Yeah, I just a kind of story of something that I saw happen. Not on the PBMU, this was at another children's facility that I was working at, but there was a Black kid that was called porch monkey and the N-word in front of staff members by another patient, one of his peers on the unit. And when he retaliated, he was the one who ended up being disciplined. It wasn't a restraint, but he got disciplined for retaliating and told by staff members, there's not really any reason to be upset because we're all descended from monkeys anyways. And so existing on a unit in a space where not only are the people your age, your peers, you know, potentially attacking you, saying just horrific things, you have then the people that are supposed to be protecting you who may agree more with the sentiments from your peers. And so just that feeling of constantly not feeling safe, and not feeling like you can trust the people who are supposed to be protecting you to actually protect you, definitely increases the likelihood of them just kind of being like, screw it, I'm going to take matters into my own hands. I can't count how many times I've had that conversation with kids of color on various units where they're like, I can't trust the staff to actually have my back, so I'm going to have my own back.
This is Jared here. I had a question about in the results, it looked like you had reduced seclusion and restraints across the board for all racial and ethnic groups, including white patients, this implicit training. And I was wondering what your thoughts were about that. They're just being used less often in general for everyone, which seems like a good outcome too. So
Yeah.
I'm wondering if you had any thoughts about that.
Yeah, I mean, I guess this is not necessarily based on research evidence per se, but one of the things I think often drives the decision to restrain or not is the level of fear that staff might be experiencing in that situation and how that impacts how they're looking at imminent risk. Because it's not like we have truly objective ways of figuring out who we think is going to become more aggressive or more self-injurious in a moment. It's kind of like a judgment call. And so this is where that implicit bias really affects people, because if people think and they're not even aware of how they might be viewing certain people, certain populations, it's going to, influence what they do. So if people are more aware of that in and of itself, I do think it would affect how they viewed the issue in general, as well as depending on which racial ethnic group the patient belongs to.